Welcome back to our final session here for today. We are very pleased to have with us Jamie Hart, who is the Executive Director of Atlas Research. If any of you have participated in some of the CMS Rural Health listening sessions that we've done, Jamie's a familiar face and has helped in a lot of the listenings that we did in developing our CMS Rural Health strategy, as well as some of the stakeholders that we engaged with as we've been rethinking rural health that the administrator mentioned earlier. So this session really is a facilitated conversation Jamie's going to step us through, but it is starting to really put pen to paper and think about how we chart our path forward. So with that, I'm going to turn it over to Jamie.
Great, thank you. And I'm going to change things up and sit down, if that's okay with folks. Okay. All right. First, I just want to say thank you so much to all of you participants and to all of our panelists for such a rich discussion leading up to today. I think, as Kara said earlier, this could have been a 3-day meeting instead of one. So there's a lot that was really packed in, and I appreciate people's ability to kind of listen, process, and really contribute. What we want to do for the rest of today, really, before the closing session, is dig into shared priorities that you all identified around improving access to maternal health care. And so what I'm going to do first is just provide kind of a quick summary. It was sort of an on-the-fly summary that we did of your comments from the stickies that were posted outside today. I will remind folks that we have a lot of folks participating remotely, and we're expecting to get more comments. Those have not all been integrated yet. They will be. We will diligently go through all of your stickies and those comments and the chat box info. And again, if you have additional thoughts or comments that you want to send in, you've got contact information, so please do so, because we'd love to take all this feedback and really be able to focus it in the summary. So what I'd like to do is to step through each topic that we discussed or that was posted outside, and that's in your worksheet, to identify some of the largest collective priorities of the group. So I'm just going to do a quick summary. And then what we want to do is then go through and identify at least one priority per topic area. And we'll probably get through 4 of the topics. It's a lot to cover. But what I'd like to do then is really lead this discussion about what you see up on the screen. So key levers. So what are those things that, whether it's legislative, policy, what is it that needs to happen to make this, to address a certain priority? What are some of the barriers and facilitators? We heard a lot about that already today, but there's some things we might want to cover. If there are relevant stakeholders that should be engaged. And it is important to think about, for a particular priority, if there is a stakeholder group that should lead it, tell us. We'd love to hear that. The time frame, how long this might take. Is it something that will happen in a week? Probably not. Is it 2 months? Is it a year? Is it 10 years? But, to think a little bit about that. And then how will we know when we've succeeded? So if we've got this priority, we've come up with these actions and activities to support it, how will we know that we've succeeded? What are those measures? And then I am going to ask people just to kind of raise their hands around impact and effort. We're not going to do a full, grid, but to see for each of these priorities, if you think that a priority would have a lot of impact and if you think it would take a lot of effort. So I do want to kind of see that from the group, and then just some next steps. So it's a lot of categories, but we'll it's a logical conversation that we'll have for each of these priority areas. And so I want to start with the summary slide here on quality and clinical and quality improvement. And again, this is one slide that summarized numerous stickies, so bear with us. But there were a number of things that folks mentioned. I think the overwhelming thing that came up was around the maternal mortality review committees, and that it's important to develop or enhance them. And people talked about including core reporting elements and including representation from health equity focused organizations. So that was an idea that came out through a number of the stickies that we saw. Care coordination was also something that came up around team-based care and coordination with remote delivery providers as a way to really look at clinical and quality improvement. And there were a number of stickies as well on engagement. So this includes engaging patients with lived experience, communities, state-level health equity representatives, state health departments, a number of different folks that can help collaborate and really make sure that experience is reflected in the clinical and quality improvement efforts. There were also a number of comments about conducting data collection and providing open source data for researchers and public health professionals. So data came up in a lot of the presentations earlier today, and again, here is a priority. And then lastly, that discussion around kind of defining and supporting level 0 hospitals so that they don't get left off. So those were some of the issues around clinical and quality improvement. Payment, again, was another issue that came up quite a bit, and I think what we heard over and over again, both in the stickies and what some of the speakers talked about this morning and this afternoon, was about paying for quality rather than procedures, and how important that is in rural areas in particular. And so how do you leverage outcomes and incentives for providers in rural areas, and are there ways to support advanced payment models that might include things like community health workers and wraparound services or other things, so that I think that goes back to that concept of the whole person and whole care. How do you make sure that those issues are being addressed as well? There were a number of comments around amplifying or enhancing birth centers and maternity care homes, and I think being able to lift up some of those promising practices that we heard about and think about how those models might be scaled. There were also comments about including rural payment strategies and rural perspectives in value-based payment programs, payment innovation incentives, quality measures, just that idea that the rural payment strategies and rural perspectives need to be integrated into all the work that we're doing. There are a lot of stickies on Medicaid, I'll just say that. And so one of, kind of in summary, it was looking at how do you use Medicaid effectively and to fund things like telehealth, transportation, doula services, interstate referrals, cost-based reimbursement, et cetera. So there are a lot of ideas around how to really expand or how to maximize the Medicaid program. And then lastly, around including OB and prenatal care and critical access costs and on the Medicare cost report. So there was kind of a range of strategies around payments as well. I cheated, and we were only going to do one slide, but I did 2 for workforce because that was just overwhelming. And I think we've heard a lot about that. And I listed a lot of examples here because I think it's important to see kind of the creativity that came out from this group around encouraging and supporting training opportunities. There were a lot of ideas around residency programs, rural rotations, community collaborations, but how to make sure providers are getting that experience. There are also opportunities to increase the number of providers, and these might be in relation to family physicians, registered nurses, CNMs and CMs with specific competencies that can help build the capacity. And then there also, I think there was a lot of discussion around encouraging and financially supporting models that include kind of expanded models of care that include doulas, midwives, women's health practitioners, kind of the range of folks that could be involved in that. And the second workforce slide really is about incentives and funding and increasing collaboration. These are condensed into some really high-level summary bullets, but one of the things that really stood out was that idea of starting incentives earlier, so before med school, so that you're really ensuring that the classes in medical school and clinical education are more diverse. And then there were a lot of ideas about loan repayment, and loan repayment in itself being really critical, but thinking about how you might expand it or how you think about it a little differently. So it's not community-based. So and I think somebody said, so it focuses on obstetric deserts, so that it's looking at things, ideas of thinking about loan repayment a little differently. There was also a really good example that somebody brought up around, that loan and payment serves as a great incentive, but you can combine it with shorter training time and a rural living commitment. And there are other ways that you can think about loan repayment that really will get folks to stay in these communities and being interested in these programs. And then collaboration was a theme that came up over and over again, actually everywhere, but around the workforce theory, bucket, it talked about, looking at innovative team-based care with midwives, family physicians, general surgeons, OBs, but really looking at that expanded collaborative model of care. And also, I like the last point about family consultation, really ensuring that, family physicians and surgeons have systems in place to be able to do that consultation. Innovation and telehealth, we sort of lumped those two together. But here, I think people talked a lot about increasing flexibility for telehealth pilot programs with payers and really thinking about how to, again, lift up some of those promising practices and make sure that, that they're getting funded. There are ideas about tools, so creating innovative risk assessment tools for triage or tools for immediate consultation so people can access different levels of care. There were thoughts about complementing telehealth with workforce retention, incentives, and pay for quality and remuneration. So that, again, I think there's a lot of discussion around the need to be able to pay for these innovations in telehealth and support that. And then lastly, the idea of some other kinds of programs like Shop Talk, where hospitals have barbershops and beauty salons that do targeted one-pagers and trainings on health topics. That's a strategy that's been used in a lot of other fields like HIV, reproductive health, other kinds of things. It's something that could easily work here as well. Health disparities, there was a lot that came up here. And I think these bullets really focus on kind of increasing the employment opportunities for the workforce for diverse communities. Really emphasizing diversity in the workforce to address maternal health. So how do you partner with folks that are looking at maternal health in rural hospitals that really are focusing on social determinants, enhancing existing curricula, and also the idea of doing implicit bias training came up as an idea as well. I think that third bullet around understanding the role of racism and inherent bias and what that plays in maternal and mortality rates is something we talked a lot about today, but really thinking about how do you integrate that into the work? How do you integrate that into the curriculum, into the training, into the delivery of care? And then also, I think folks talked about investing in programs, looking at, maybe you do some prioritization around some of the top health disparities, that you do research that focuses on diverse communities, and that the LGBTIA plus community is included as well. So there are a lot of things to think about there. And then sort of related is that idea of the social determinants of health. And so, some of the stickies that we saw were about really being able to do an evaluation of the Medicaid supported services and what are some of those barriers to utilization. We talked about that this morning as well, but what are some of those barriers related to the determinants of health? But I think the flip side of that is also what are the protective factors that some of the determinants of health can provide as well. That any planning, evaluation, implementation, any of that includes the social determinants of health. And then there were a couple of comments about transportation and how critical that is. I think we saw that in pictures today. We heard that over and over again, that transportation in rural areas is really a critical issue, particularly for some communities. And so what are those barriers and how do you address those with funding, not just a nod to the fact that it's an issue. And then I think public education and public health. Here there was some discussion around providing coverage for nursing homes and postpartum nurse home visiting programs, collaborating with health departments and other community partners and patients. Again, you see that engagement piece. Collaborating just beyond medical doctors and thinking about who else needs to be at the table. That idea of working with community health workers and CHEWs. And then also there was a comment about integrating mental health and domestic violence care into maternal health care. So really kind of expanding the way we're thinking about maternal care and making sure that we're covering some of those broader public health or population health issues. And we're almost done. Legislation was one that came up. And so this was about, funding for the Title X MCH Services Block Grant and what would be required for that. Expanding Medicaid or CHIP coverage to 6 to 12 months postpartum. Expanding and sustaining obstetric units in rural areas. I think that came up a lot about how critical that is. And reducing variation in benefits across the continuum. And then lastly, really looking at regulatory barriers. I think that came up quite a bit around the legislation issues. So how do you support collaboration versus competition to make sure that folks are getting the care they need? And then the last slide is just other. And so this was, thoughts about considering the role of malpractice or liability insurance in the decisions to close rural obstetric units, and that's something that needs to be on the table. Creating location-specific resources and guidelines for pregnant and parenting women in rural areas. Sometimes it's a lack of knowledge and understanding about what access looks like and how you get to those services. And then, of course, supporting payer-provider collaboration. That one actually could fit in many of the buckets, but we put it in other because it cut across so many. So that's a really quick summary of what we saw. And I think people did a really great job of kind of integrating the information you received this morning and this afternoon with your experiences. And I want to stop there and see, did we miss anything? Is there a glaring error? Anything that you really want to see? And if I could ask folks to go to the mic, please, because we do have folks online, that would be great.
Can you hear me? Yeah.
Yes.
Skip Johnstone. I'm faculty for a residency program, OB/GYN residency program in southeastern North Carolina. And it's my fault that it was not put on one of your bucket boards.
That's okay.
Because I thought it would come up. But we heard a story from Louisiana earlier in the discussions that involved substance use. And I just felt like somebody else would put it up there, so it's my fault. But we need to address substance use disorders, especially in the rural maternal population, because that, according to CDC data recently, is where the problem is growing rapidly.
Great. All right, we'll make sure that gets on the list. Thank you. Yes.
Jean Howe, Indian Health. I'd just like to make sure that the emergency room readiness is on the list. There are many rural communities where there's been such a dramatic population shift that it really isn't feasible to reopen, at least in the short term, birth facilities that might have a birth a month. But there are still pregnant women that will show up in those emergency rooms, and those emergency rooms need help being ready. Just want to point out that they're often staffed by contractors, so there isn't a way to get traction in an individual ER unless you look at what people are trained to do nationally and what the national standards for ERs are to take care of pregnant women. There's probably no more dangerous place to be right now than an ER in a hospital that closed its labor and delivery, where that ER doesn't know what to do with her and she can't go where she usually did. So thank you.
Great, thank you. Good, another comment? Yes.
And I'm not sure if you mentioned it, but the importance of drill, the AIM program is really critical for those low volume occurrences that you need to be ready for right at that time. And I guess the only other one was we had some mention of the teaching health centers and making sure that you have rural residencies. We really do need to expand the number of residency slots anyways. But we really need, where we need to expand them is into rural communities, and the Teaching Health Center program is a good way to do that.
Great, thank you. Yeah, and I just want to remind folks that I appreciate those comments, and we did capture all of the detailed bullets, and we're going to get all of the information from the virtual participants as well, so we're going to integrate all of this. This was a summary, but we tried to capture a lot of the kind of key points, but I appreciate you pointing those out for sure. Other thoughts about what might be missing? Oh. Can we go to the back first? I'm sorry.
Thank you. No problem. I just wanted to be sure that extension of Medicaid was something that was being included.
Absolutely.
Thank you.
Yes, thank you.
So I'm Brock Slabaugh with the National Rural Health Association. Just wanted to put on the table the expansion of Federal Tort Claims Act liability, or FTCA protection, for providers in rural communities delivering obstetrical services, and what that would do to reduce or at least eliminate the issue of medical malpractice as a condition of inhibiting people's entrance in rural communities. The other thing is looking at trying to how we address, and I know the issue of commercial payers have come up, and I was surprised this morning to see nationally 61% of deliveries are paid through private insurance. Somehow convincing, either through finesse or through legislation, recognizing the high unit costs in rural facilities that have low volumes and making sure that those contracts reflect those numbers. Because what happens is, as a hospital administrator, when I worked in rural Mississippi, we would get the template contracts that were meant for hospitals in Jackson and Baton Rouge, and they dictated to us what our per diem was for delivery. And we would try to negotiate a difference, and they would, basically say, no, this is what we pay in Baton Rouge and Jackson. So, I think we need a little bit more education of what it costs to run these units in rural facilities, with low volumes being the driver for those higher unit costs. And if we're going to have access, that's going to cost something. And I think everyone needs to recognize the reality of that perception. The other thing I would like to close with is, we used nurse midwives in our team of professionals delivering services, obstetrical services at my hospital. And I'm pleased that we were the first Mississippi hospital to engage a professional nurse midwife in a hospital-based practice. So, it does work, and it's a great it's a great program to use to be able to keep the program open in your hospital.
Wonderful. Thank you. You had a comment in the back?
Yes, this is an area that I'm a little bit less sure of, but I was wondering, because I hadn't heard this mentioned in previous panels, about if there's kind of growing interest in investigating potential exemptions for pregnant women who are recently incarcerated but then lose coverage during that period, because I thought that would be, an area of growing concern with the opioid epidemic and such. So I just wanted to add that to our considerations.
Great, thank you.
Thank you.
Appreciate that. Any other thoughts on what might be missing? Okay, all right. So what I'd like to do is actually, Sarah, if I could ask for some assistance in the back, if we could go back to the clinical and quality improvement slide, and we'll start there. And what I would like to do is take a look at the bullets under that slide. I would sing or tell a joke, but you don't want to hear that anything I would say or sing. So we're going to go back to this slide, and what I'd like you to do is take a look at those bullets. And we have a large group, but I'm going to ask us just to do a little bit of prioritization. And if there is something that really stands out to folks, what I'd like to do is be able to start there and go through that process of talking about kind of the levers, the stakeholders, the barriers, facilitators. So, we've got the maternal mortality review committees, care coordination, engagement of patients, communities, et cetera, data, and then level 0 hospitals. Does anybody want to get up and get us started with one of these kind of big buckets? Now's not the time to be shy. And if you get to the mic first, then your priority gets preference. All right. So we want to start with this. And so tell us which one is the one that you think we should start with.
2.
Number 2. That's the supporting care coordination?
Right.
Okay.
Right. I just, when I think about what we're doing, and, I worked in a little tiny, the last hospital I worked in was 25-bed critical access. Average daily census was 15, and we did 125 births a year. And so the thing is that if we just keep doing the same thing we've done, we're going to keep getting the same thing we get. And so we've got to really think about what are the other services that these families need. And it's not just medical care. It's I think that midwives can be a big help, but I also think community health workers could be an essential part of this. And I think we're a little bit hospital-centric. We're always thinking about the hospital, and there's this whole other community out there. So we need to find out what, where's WIC? How are we working together collaboratively to really provide services? And we've got to change the system. We can't keep doing exactly what we're doing by improving medical care in the hospital.
Yep.
We're not going to get the results that we need. So
great, thank you. And we're going to stick with this priority area. So I think you've got a comment in the back, and I'd love to, if you've got, we're sort of filling in the boxes. So if there are levers that might make some change here, that would be a great place to start.
My name's Lacey. I'm from Kearney County Hospital in Lakin, Kansas. And we are rural. And I was going to say care coordination also. So I'm very happy that that's what was brought up. I think a lot of the other things that have come up all fit under this one particular issue in terms of engaging our public health, county health departments, different things like that in order to, and then training for our registered nurses and others to be equipped to be able to do a little bit more assessment of those social health determinants if they're doing home visiting and things like that, to be able to know how to interact with patients who are expressing that they are opioid dependent or other things. How do they take those first steps to continue to engage that care? So
great, thank you. And I want to ask folks, if I could see a show of hands, how many people would have picked care coordination as a priority? Okay. All right, good. That seems like a lot of folks. All right. So you have some more comments on levers or relevant stakeholders?
Well, I think the the level 0 hospitals, and specifically that we want to try to prevent more hospitals going to level 0. This is really at a crisis point at this point, just because we're just losing OB programs left and right. And so I think that as a result of that, we've already heard some about the obstetrical deserts that are developing, and this is something we need to address now. I mean, this is as of last month. This is a critical issue.
Okay, thank you. And we're still talking about care coordination. That was another one. Do you have a different priority? We'll do yours, and then I think we're going to go back to care coordination, but go ahead.
Okay, I just wanted, or I can wait. Okay, I just wanted to plug for patient and community engagement, because I think that in the end, this is all about amplifying the voice of the communities, listening to them about what their needs are. One of the things I learned by serving in rural communities is they're willing to tolerate risks in a different way than we are, urban dwelling people. And I think it's really important that we design the system around them, by them, for them. Again, beginning with the workforce development, training the people in their communities to serve their communities.
Right. Great. Okay. All right. So this is why I like to sit next to Kara, because this is an iterative conversation that we always have. So if we've got the 3 priorities that folks just talked about, 1 was care coordination, 2 was level 0 hospitals, and 3 was patient and community engagement. I would love to see a show of hands. I'm going to go back through those, but if you had to pick one of those 3 as your top, how many would say that care coordination was the top one? Are you counting? How many would say level 0 hospitals? You only get to vote once. You want me to flip you? Okay. And then how many would say patient and community engagement? I think care coordination, and then, yep, okay. All right, so let's go back to care coordination. And we talked about some of the levers that would make this happen. So training came up, a number of other kinds of issues. Who are some of the stakeholders that would need to be involved in this? Yes, for care coordination, please.
So, broadening this conversation a bit is looking at regional approaches to how we coordinate care across distance. So where do we do prenatal care, and how can we open access points in communities that don't have hospital-based services? And how can that be then regionalized to have appropriate handoffs at the appropriate level of gestation so that they'll have their delivery then at that other location? So I think we need to think about this more, holistically, rather than just in one community. It's both and, really. But
Sure.
I mean, how do we outreach to those other communities for that service?
Yeah, and I think the question too then is, what are the levers that would make that happen? Are those policy changes? Are there, what's going to help that kind of state or cross-county collaboration?
Yeah, and that's an excellent point. And I think that what I've seen work really well is learning collaboratives in a regional context to organize, and going to the previous comment, having individuals from those regions and those communities getting together and discussing the problem and seeing what resources they have to bring to bear in their solution.
Great, thank you. Yeah, please.
I'm going to cheat a little bit maybe and try to have my cake and eat it too. But in the relevant stakeholder area, I think community and patients should be included in that conversation.
Good. That's not cheating. I think that's good. That makes sense. Great. In the back.
Just to follow up on that, I think it's important that not only are we educating providers, but we are educating the patients, because they are ultimately the person who has to navigate all of these touch points, and we need to educate them and empower them to speak up when something doesn't feel right in a provider's office, and realize that those settings can be very intimidating, especially if you're from a rural community and not used to those types of services.
Right. Great. Thank you.
Hi, I'm Kimberly McKay. I'm from Vera Health in South Dakota. I want to put a plug in here for open data sources. And the reason is because clinical quality improvement is not going to change unless you understand your ecosystem. small hospitals have zero incentive to pay for quality improvement because they're making a choice between bedpans and paying for somebody to collect the data. So those are the cold, hard realities. To have a system in place that allows them to do that seamlessly, cheaply, easily would be a really important piece of this collaborative around the care coordination piece.
Great, thank you. I was going to mention too, thank you so much for the video and your interviews. And I grew up in Watertown, South Dakota, so yeah, for real. And my mother's going through those things of driving 2 hours to Sioux Falls for care, so I'm with you, although I'm totally an urban dweller now. Thank you. Great, so we've talked about a couple of things like, oh, yeah, please. Good exercise since you've been sitting all day. So yes.
I'm Carol Sakala, and I'm with the National Partnership for Women and Families. And a barrier is payment, and who is resourced, tasked, prepared, and accountable for doing this work. And I'd just like to comment on a learning from the Truven Health Analytics Cost of Having a Baby report that 4 out of 5 of all dollars paid on behalf of the woman and the baby across the whole episode of care fall in that little interpartum window. That's why we have 15-minute hurried prenatal visits, and that's why nobody is out there to say, oh, you're a smoker, you're experiencing intimate partner violence, I'm going to help you. So this can cross over to the payment bucket if we make this a payment reform on the model of PCMH.
Great, thank you. I see some, go ahead, it's okay to clap. Great. Any other barriers that folks want to mention before we move on to some facilitators? Please.
I think you need to train people to do this. I mean, if you're training people, not an interprofessional team, and then you put them out there and you say, do this, they don't know how. So the training part needs to be part of whatever you do.
Absolutely, yeah. And so lever, but I think you're right. It's a barrier to not have the training. It's absolutely, training can be a facilitator to that success. I also heard things like, I think open data sources is kind of a facilitator in many ways. I think the use of working with community health workers and other parts of the healthcare system, or not the non-traditional healthcare system, however you want to refer to it, is important. Are there other facilitators that folks think are really important to support care coordination? And again, all this goes back to the idea of kind of quality of care, improvement of clinical care, but are there other things that would really help, that have helped in your communities or that might help improve care coordination? I see why this is a priority. Then, yeah. How do we know we've succeeded? If we're really trying to improve care coordination, what's the outcome we're looking at? Yeah.
Another facilitator is the perinatal collaboratives.
Perinatal collaboratives was mentioned as another facilitator. Great, thank you. I knew if we waited long enough, we'd get one. Can you come to the mic for the folks online? And I think you were going to add another facilitator. Great.
I'm Lucia DeVenier. I'm with ACOG. Interprofessional training at early stages in the medical student's career would be very helpful to achieving this.
Great. Thank you.
Tim Putnam with Margaret Mary Health in Batesville, Indiana. And I admit that I'm acute care focused, hospital centric, but we have to realize in a lot of these rural towns, the only organization that can be a facilitator is the hospital. It's honestly the only thing left. I mean, a lot of them, the high schools have closed, the businesses are gone. There are churches that kind of get engaged, but they're all sort of volunteer, part-time basis. There's no other organization that can be, in the rural areas, be the facilitator. City, county governments can't function like that. So we have to realize that a lot of this has to go through the hospitals. And from my perspective, the payment mechanisms, I am paid to do stuff to people. We're paid to deliver babies. That's a tangible thing that insurance companies, Medicare, Medicaid, all the others can get behind. What I want is really good outcomes, but I'm not paid for doing a lot of these other things, smoking cessation, putting effort toward that. The payment model reform, and CMMI has been great about coming up with different ideas on payment model reform, but just pay me for the outcome and I'll do that. But right now I'm getting paid to do stuff to people.
And are there, I mean, I think you make a really important point that the hospitals really are the only facilitators in some places. So payments, one thing. Is there anything else that sort of incentivizes or helps hospitals support that care coordination?
I think holding the mirror up to them and tell them this is your mission statement is a really important thing. I mean, you have to realize that when a huge storm hits a rural area, the hospital is the only thing left with the lights on. And they hold that mission to improve the health of the community and care for the community sacred. They also have to keep the doors open, which many of them haven't been able to do that.
Right.
So I think the only thing beyond the payment of being able to do that is holding that mirror up, saying your mission statement, and you can look at any one of the 2,000 rural hospitals in the country, their own mission statements say the same thing. It's to, yeah, I'm sorry to break it to everybody, but the mission statement is to improve the health or care for the health of the community.
Right.
And so holding that up to them and saying, hey, you're charged with doing this, and it's time. And we all know it's not building it. And we used to be trained to build a great house and make your hospital, your building as good as it can be and the things that take care of that. Now we're all trained and focused a little bit more on building a great neighborhood. So we know we need to facilitate that. So I think some of that, it's just holding that up to the hospitals and say, fulfill your mission to the organization. So I threw all my colleagues under the bus. I'm sorry. I'll stop there.
As long as you look in your own mirror.
Tim,
Yes.
before you sit down, so if you said you get reimbursed for doing things to people and we need to change that, what would it take to change that?
We've been very big on the transition from volume to value, and everybody talks about that, having one foot in a canoe, another one nailed to the dock. And I get it. We can't move away from that. But we've seen some things by being involved in the ACO that we can make the investments to improve health outcomes, and it decreases overall health care cost. So, I've been involved in that for 4 or 5 years now. I see things like the Pennsylvania Global Payment Model may not be the answer, but give me the cash to do the right things, and I'll do them. And especially in a rural community, because we're in these areas, in Valdez, Alaska, and Batesville, Indiana, I've got a pretty small population. There's a population, you can do this population health stuff. So give me what I've been getting to do stuff to people and tell me that you want better outcomes for the same amount of money or even less. I think we could do it.
Thank you.
This isn't recorded, is it?
Yes, and you introduced yourself, so your name.
I really do support everything that he said. I also support what I was trying to refer to was what Carol said so eloquently, that we spend so much of our money on the interpartum care. And the hospitals are the facilitators in these little towns. That's often true. Often there's a public health department, maybe some WIC, some other things going on. But you also have to be careful, because when you're a nurse working in these little hospitals, you are told that the physician is your customer. That's who the customer is, and so you have to let the physician practice that way they want to. You have to facilitate that. You have to serve that physician. I'm not kidding you. That's just the way it is. And so you have to be careful. You say that's the facilitator, and where's the payment going to? It's going to the hospital, and it's going to the physicians. And that's just the reality of these little rural hospitals. So how do we change that narrative to put money? And, I like can't remember your name, but maybe he didn't introduce himself, but, what he said is, what are the outcomes that we're looking for? And it should be paying for outcomes. And that was said earlier today, not just paying for, doing things to people. So.
Right. Yeah, and I think that sort of gets at, my question was about, the next question was around indicators of success. And so, a shift to being able to pay for outcomes and seeing changes in outcomes versus the number of procedures, et cetera, is sort of one of the things that we would be looking for. Are there other ways that you would know that the system was successful if care coordination was better than it is now in rural areas?
Well, we have to stick with the National Quality Forum endorsed metrics, and people will stop dying. That'll be good.
Thank you. It's not the only outcome, but it's a big one, right? Okay. All right. Let me ask, I'm going to ask for a show of hands about impact. So when you're thinking about supporting care coordination, improving care coordination in rural hospitals with the ultimate goal of kind of improving quality and the delivery of care, how many people think that this would have a high impact in access, delivery of care, et cetera, in rural areas? Okay. How many people think this would require quite a bit of effort? So I saw people kind of raise their hands for both. Same people. Yeah. Okay. I think more on effort. Yeah. And are there, so part of what, we're trying to do here is get feedback from you all and think about what some next steps might be, for CMS, for the stakeholders, for the different partners that are involved, for you. Are there any thoughts about some critical next steps that should happen to get moving on this idea of improving and supporting care coordination in rural hospitals? Anything that you think would be important to do to gain some momentum? Yeah, and can I ask you to, I'm sorry, I know we have one mic, I apologize. How do we eat the elephant? That's what we're asking.
Hello, my name's Nicole Purnell. I'm with Mama's Voices. And I would say that one of the things would be to make sure that states across the board are adopting the AIM bundles so that there's a standardization of care. When you're talking about care coordination, that's oftentimes for the patients pretty scary because it's not always the same level when you're getting transferred from one person to another.
Yep. Great. Thank you.
Hi, I'm Dewana R.D. Calhoun with Self-Made Health Network, one of the CDC's national disparity networks. I would say I have just a basic answer. Perhaps just funding some models and also ensuring that the funding involves investing in community organizations as well, so that there's support for not only the hospital but for the patients along the continuum of care.
Great, thank you.
I know I have to be creative and not just go to cash, but it's cash. Without that, it's tough to be creative. And all of you may know this, but of the 2,000 rural hospitals, 1,300 are critical access. Critical access are cost-based reimbursed on Medicare patients. Very few of the deliveries at my hospital are Medicare. So I have to, it's surprising, I know, it's a shock. But the idea, and cost-based means cost, I mean, basically, I can show you the math, but we'll lose about 5 to 6% on Medicare patients, which is awesome because before we lost about 20% on Medicare patients. So that we're real excited about only losing 5 or 6%. But there's a theory that it's kind of like when they put cost-based reimbursed for Medicare and kept Medicaid out of it, that the federal government, state governments wanted these things, the OB, not to be delivered in rural areas. Because for every obstetrics patient I have, it cuts my cost-based reimbursement because my percentage of Medicare goes down. So this, I mean, if you just, I mean, it's not about not being profitable or anything like that. It's if you cut it out, you cut all the expenses and your reimbursement for Medicare goes up. And that's why the hospitals have cut it down. So we've got to change that mindset, that methodology. And I know it's a state-controlled issue and things like that, but that really is at the core of it. So.
Thank you.
So as we're thinking about networks, this reminds me a lot of the concepts that we came up with, the pilot program we're funding this year, the Rural Maternal Obstetrics and Management Strategies. And the thought we had was that even if it's a Medicaid covered service and you can have a better outcome, and you avoid some NICU stays, you've paid for the grant we're providing. And then also, if it's uninsured, then it's bad debt at that tertiary anyway. I feel like there's enough money in the system. We're just paying for it in the worst possible way. And so what we're hoping to do with this pilot program is stitch everybody together, rural, urban, ambulatory, acute, and the full spectrum from prenatal, perinatal, postnatal, through home visiting, all of it together, with an idea being that if they all pull in the same direction, they'll reduce their bad outcomes, and the grant hopefully will pay for itself. That's the theory behind the whole thing. And earlier today, it was interesting, the word regionalization came up. And I know when we've described this program, we've used the word regionalization, and that makes people in rural recoil because they think somebody's going to run things for them. So if we can take the baggage off of the term regionalization, what we really are talking about here is regionalization, because all of this stuff is happening on a regional basis. And so, I think having private payers, Medicaid, they're the ones bearing the worst part of the costs. So they have the most incentive to have the outcomes be good. And if we can get them all together to think about how we can support the stuff that Tim doesn't get paid for, then maybe there's a way to move this forward.
Great, thank you. Let's do 2 more comments on this, and then we'll actually move on to the next one.
And actually, it's sort of along the same lines, and we've talked about the maternity levels of care and how that really is a responsibility from both directions. I think that if we talk about regionalization, that the tertiary care center hospitals need to really support rural communities. I think that's great, but it has to be, so I really like the idea of the stakeholder being the communities themselves, because I can tell you that a lot of times tertiary care hospitals have no idea how rural is or how small is, and they have to take that into account and not just assume that they know best, even though they have the bigger budget.
Right. Isn't it about how close you are to a Starbucks? Is that what we talked about earlier today? Walmart. Target, Walmart, yeah. Walmart.
We're 30 miles away from Starbucks, but and that's a big deal for me because I moved from 100 miles away from Starbucks. So this is Lacey again in Kansas, and or I'm in DC, but I'm from Kansas. So I think another thing that I would really appreciate is redefining some of the definitions that we have, like what does underserved mean? When you live in a rural area, everyone is underserved, whether you are insured, uninsured, or underinsured. Whether you have your socioeconomic factors, your income, and all of those things. And a lot of times when we get grants and different block grants, different things, programs, pilot programs, they really want us to focus on our vulnerable populations. And how do we do that whenever everyone in our geographic area is a vulnerable population? So kind of helping us redefine that, and then that will trickle down through the funding and different things like that too.
Absolutely, thank you.
Just a comment. I think that there have been a lot of groups that have looked at the issue of perinatal regionalization, and we're not using that term anymore. It's really risk-appropriate care, because not everybody is really sick. Not everybody needs a level 3 or 4, and in fact, some people need to be put back in the communities that they are in. So so again, we have to think about it both ways, particularly in rural settings. There are often these times when a baby needs to return to the community so that they can convalesce. And so we need to keep that in consideration. But the problem currently is there's very few transport systems that are paid for to send a baby back. So that's something that I think we need to think about. And then the other issue about this level 0, there isn't a level 0, just as a point of clarification. But the question is, should community facilities be prepared in the case of the need to deliver an infant? And then also, what are some of the issues with regard to EMS systems, transport? We didn't talk about that. There are a lot of EMS systems that do not know how to intubate or put in lines for people who are in shock. So what do we do? In developing countries, we've done some very basic teaching on airway maintenance and access that maybe we need to use in the U.S.
Great. Thank you. Thank you. All All right. This was great. We appreciate the feedback. And I apologize. You know, I see the world in grids and tables, but it limits me sometimes. And folks, about where things fit, don't worry about that. We'll do some massaging and move things around, but it at least helps us think about the questions we want to ask. What I want to do is actually go back to the slide on payment, if we could, please, Sarah. And I just want to remind folks of what we talked about here. And there was a clear winner in terms of the number of stickies that we saw. So we talked about paying for quality, which came up here, about birth centers, maternity homes, rural payment strategies, and OB and prenatal care under critical access costs. But the providing Medicaid funding was the number one vote getter. So I'd actually like to suggest that we talk about this as a priority for a little bit. How many folks would be okay with us talking about Medicaid? Okay, we win. Just a couple. So what I want to do is just Sarah, if we could just take that bullet around Medicaid funding for things like telehealth, transportation, doula services, et cetera, and then go back to that template slide where we want to talk about kind of what the issue is and what are some of the levers. So I'm going to ask folks to come on up to the mic. You can talk I'm going to ask about levers, but you can, if you have things that fill other boxes, it's okay.
Brock Slaybaugh, National Rural Health Association. Sound like a broken record this afternoon, but in the area of Medicaid reimbursement, particularly as it relates to small volume facilities, states have, in their federal state partnerships, have went to Medicaid managed care to help with the expenditures in their state governments. And what that's done is removed, really by one factor, the relationship between the state and the provider in negotiating rates. Mm-hmm. And so now rates are negotiated with commercial companies for coverage, whereas before it was with the state Medicaid agency. Mm. And rural hospitals do not have the insurance literacy to be negotiating these contracts, to be getting the cost of care back for the deliveries that they're making in their units. Mm-hmm. And that's a technical assistance requirement. It's also compelling the companies that write these policies to make sure that they cover the low volume costs of these facilities in rural areas.
Okay. So that I like that. You kind of covered the barrier, facilitator, and a lever all in one. Yeah. So great. Thank you. Yeah.
Hi, Katie Cosimanel. Medicaid, so one thing that I want to elevate is in the research that we have done in rural communities and talking to rural mothers and rural families, what they have said is that their largest barriers to accessing services, those that are low income, that are Medicaid beneficiaries, are transportation and housing. Mm-hmm. And housing's not up here, but I think it's an important aspect for folks that have to travel a long distance. And I think one of the barriers that we're talking about here that's general to all of these topics is that Medicaid is health insurance, and we need to be careful in thinking about using health insurance to address broader other structural issues that also need to shift, right? Like you can't just use it to fill the gaps without changing the structures that created the gaps in the first place. So I think that's an important barrier to be aware of, or contours around this. That said, those are the two things that I hear all the time when talking to rural moms and communities. Housing and transportation, and there are ways to do that, and we've seen state Medicaid programs that have done that, including waivers in Alaska, where they have maternal homes where folks come when they're 37 weeks gestation and stay nearby because it's cheaper for the Medicaid program to do that and provide housing for folks. You can also do housing vouchers and other ways of providing places for people to stay than it is to do emergency medical transportation or handle high-risk births in very remote locations. And I think so I would just add housing to this this space as well. I also want to just talk a little bit about doula services, which is something that I've done a lot of work on. And first, I want to say that doula services are an incredibly evidence-based intervention with no known downsides and are really good overall investment. And it's a community-based intervention where the demographics can be matched to the folks that are giving birth. Frequently, the demographics of our clinical care teams for maternity services do not match the demographics of the folks that are giving birth. And so I think this funding doulas, funding community-based supports, community health workers is one way to do that. So that's something that Medicaid can do. That said, Medicaid reimbursement for doula services is not a panacea, and we cannot expect that to solve racial inequities. We cannot expect that to solve the maternal mortality problem. We cannot put at the feet of the lowest paid group to solve a problem that was created by a very resourced system. So I think that is something to kind of keep in mind as we talk about doula services. In terms of the sort of another barrier or in the doula services spaces, we don't have like one community voice that speaks on behalf of doulas. There's not a professional society to negotiate with. So that's something that's a challenge. Facilitators these are folks that are in the communities themselves, and the services, transportation, housing, doulas, like supportive people, those are there in rural communities. We just need to find ways to bring them together and to fund them to do this work. So that's a lot of things, but I had a lot to say about that.
No, that's great. And I think we're capturing it. We're also doing really detailed notes in a recording, so I appreciate that. So I just want to make sure that, what I heard was about using the idea of state Medicaid waivers to be able to cover some of those services is really critical, and then thinking about doulas as supports. And I think the real takeaway is about what you said about you can't fill the gaps if you're not changing structures. And so that idea, I think we've heard over and over again, and how important that is. So that Medicaid is one way to deal with some things, but you've got to have these other strategies around workforce development, around payment, around, that's where we get into that problem of trying to separate everything. They're all so connected. Thank you. So let's go to the back, and then we'll come back up.
Okay, thanks. Lucia Devenier with ACOG again. I just wanted to respond to the suggestion of Medicaid payment for doulas, which we definitely understand that doulas have a place in the whole continuum of care and can really be incredibly beneficial to moms and to women who are pregnant and birthing. I think when you start talking about Medicaid, federal and state dollars going to various kinds of providers, I think the most important thing that was mentioned was that there is no professional society, there is no definition, there are no particular qualifications. So that would be our I don't even want to use the word concern, but I think that's an important point that we need to keep in mind, that if we're going to be asking for federal and state payment to go to individuals who are providing care, it certainly is something that we think is important, is that we ensure that the people providing care are qualified, we know who they are, there are a set of standards, a set of definitions of what that care entails, and we would definitely want to put that in the conversation as well.
Great. Thank you so much. Thank you.
My first comment is, as we're thinking about value-based care, remember there are no benchmarks for what quality means in a rural facility. So we have to be a little bit careful of applying a tertiary care standard to our critical access hospitals. Number two, as a telemedicine provider, one of my largest sort of pain in the butt things, can I say that here, is credentialing in a facility, and that's source where, like, I provide a mobile health service for gestational diabetes for my rural patients, but we can't get paid for them because it's in the patient's home. We've been working on it for 3 years to get that policy changed. It's still unclear as to whether or not it's going to be paid for outside of our own policy. The other piece is around credentialing within hospital facilities. So if I'm going to bring expertise into a critical access hospital, I have to be credentialed as a physician in that hospital. Just like I could walk through that door in person, I have to have that same credentialing. So there's got to be something around that piece that changes, because otherwise that's still going to be a 6-month process. And then the third thing I would put a plug in for is sort of that cross-credentialing for Medicaid services for those of us in border states, so that we don't have to get credentialed for Medicaid in 3 or 4 places. We just do it maybe one time. And I know that's a 10-year plan probably.
That doesn't mean we're not going to write it down. I think that's a really important point that people have been bringing up.
Hi.
Hi.
I just want to add to Lever's templates for state legislation. When I look at things like TA to rural hospitals on negotiation with managed care plans, I just want to inject that with a dose of reality and say that's probably, there needs to be more accountability around differential payment models to rural hospitals that goes beyond sort of coaching on negotiation, that there's real teeth in what's happening with hospital acquisition in a lot of states, mergers, and so there's going to have to be something that's a little bit stronger that sort of resets the balance of how hospitals are paid, and that might need to look legislative. I think in general, the other major barrier here that we're not talking about is that when we put the onus on state Medicaid agencies to adopt costs, and I think Katie's comment was getting at this, for expanding telehealth services, for covering non-emergent transportation, that money is all coming out of a state budget, and the state budget is legislatively managed. And so when we think about relevant stakeholders and tools, I think, how do we make sure that there's some kind of incentive or federal match for high priority services that helps states get beyond the barriers at the state level for vastly increasing our Medicaid budgets? We don't just have money coming, from nowhere. So I hope the word the phrase Medicaid expansion can figure somewhere in this figure, because that is a way in which states draw down federal match for new and innovative programming, and that can help with actually accomplishing some of these goals.
Great, thank you. And I definitely want to encourage, as you're coming up, if we heard a number of things about different stakeholders that should be involved, so state Medicaid agencies, state legislators, ideas about, I think, doulas and societies represent, if there's a society that could represent doulas, so there are a number of things. So if you have other comments on stakeholders, please share those as well.
I just wanted to add a quick addition to the question about Medicaid covering transportation and housing. I work closely with maternal homes in Alaska. And then one thing is that when it's included as part of the healthcare, it sort of becomes coercive in the sense that if the patient doesn't come to her next visit, if she doesn't follow the provider's recommendations, if she doesn't follow the guidelines, if she doesn't come in for her recommended scheduled C-section, her housing may depend on that, her transportation to the hospital in the event of an emergency may depend on that. And I've seen patients where they did not want to comply with what was recommended, but they knew that they would lose their meal voucher or whatever. So if there's a different way to fund it other than Medicaid where it's directly tied to the care you're getting, I think that's a really important consideration, especially for the patients where they might be in a Medicaid HMO and they can't really choose their provider, or they're limited in where they can go, and they may not be empowered, since that's part of what we're talking about here too, community involvement. So it's a really fine line, but I think it's important to a lot of people.
Yeah, thank you. Thank you. All right, and I want to throw out the question too of, if we're thinking about looking at changing some of the models around reimbursement and changing or supporting expansion, what do we know? What's success? What are the things that you want to be able to see if we start implementing things like, if states have the ability to better negotiate with payers, if what do you want to see with all these changes around the Medicaid program? I mean, obviously it's better birth outcomes and maternal outcomes, but are there other things that, in a year or in 5 years, how will we know that we've made a difference? And what is it, eating part of the elephant? I think PETA would not like that, but yes.
Well, I think you just hit on the biggest one, which is that we have fewer moms and babies dying. That's the most important.
Yeah.
Beyond that, I think in terms of the short term where you can really see it, I think if we can stabilize these rural hospitals and OB programs, I think that would be really useful. And I think that's where the having Medicaid funding of obstetrical services in small rural hospitals is really important.
Great, thank you.
Keep talking because this is my favorite subject.
It's
but
okay.
I think a couple of easy things to follow are discharge diagnoses of the MSDRG of C-section with and without complication, and vaginal delivery with and without complication, to be able to move patients from those complication delivery codes into those just run-of-the-mill. It was kind of boring. Pretty easy outcome. And then first trimester care access is something that Medicaid does follow very closely. So following that county by county and being able to move the meter there, that makes a difference.
Great, thank you. And I do want to remind people to think about, before, during, and after pregnancy. We're talking about the continuum too. So,
I would just add to indicators of success, increased occurrence of Medicaid reimbursement of advanced practice nurses, mid-level providers, birth center models, shifting the reimbursement, where the reimbursement is going to other models that are not just birth hospitals, I guess. And then the other thing is that one thing we're trying to do in Louisiana is mandate stratification of key quality measures by our managed care organizations, not just by race and ethnicity, but also by urban and rural status. And I think if we had a more homogeneous mandate around that, there would be a way of tracking a reduction of urban-rural disparity in key Medicaid quality measures in our core set over time.
Great, thank you.
I just wanted to say patient satisfaction would be a very important indicator. I wanted to also speak to this issue of, I wonder sometimes if we're setting up a barrier by giving a woman a Medicaid card. And the reason I say that is I've heard these comments all my professional life. Oh, she's on Medicaid. That's a Medicaid patient. We don't take Medicaid. That system doesn't take Medicaid because it doesn't pay enough. And so I wonder if we're almost setting up a barrier by labeling her as a Medicaid patient. And I wonder if there's another way to label it so we're not using labels in that way, because it does get very derogatory. It can.
Great, thank you.
Hi, I just want to add on, hi everyone, it's me again, at a microphone. There's so many things I'm so excited about for today, so thank you for having this conversation. To add to the point that Pooja made earlier about measuring by rural and urban and standardizing that as part of what we do, I think is very, very important. I also want to say that there are lots of different measures of rural, and we need to look within rural areas as well. We've seen these racial disparities issues. If we just look at rural areas alone, where we still have a majority white population in a lot of places, we might miss, especially for American Indian Alaska Native folks or Asian folks or other groups that are living in rural areas. It is so important that we look within rural areas, and not just by race and ethnicity, but also by remoteness. I talked about the findings of our study on loss of obstetric services in rural counties. We found different effects based on whether or not you were adjacent to an urban area. We need to be looking within rural at the most remote places, at the places that are the least population density, and so using the full range of that. And I know not everyone in this room is a rural health practitioner or researcher, but I just want to elevate that for everyone that's in this room that cares about these issues, that we do more than just a rural-urban dichotomy on a routine basis, and that we ask these questions if we see those disparities within those rural communities, who is hurting the most? Where is this? Where is this? Or where are the improvements showing up the most? So, thank you.
Thank you.
And Katie, do you have a preference for which of the 15 rural definitions you'd like us to use?
There are so many preferences about that. I think part of it, I just did a long talk on this at the National Rural Health Association meeting, but I think it matters sort of what data are available, if you have it at the county level, and also what is the purpose? What are you asking the question for? Who is making decisions about it, and what data do they need? Do you need it at the county level? Do you need it at the zip code level? Do you need it at the congressional district level? And then we can use definitions that make sense for the question. So I think that would be a question. Probably in most states, county levels are good administrative unit levels. And so there are a couple of definitions. I think the rural micropolitan, so small town versus non-core, less population density, as well as adjacent and non-adjacent, is probably the best, most basic way to do that. You weren't expecting like a real, actual answer. We got it. We're there. Thank you.
I was going to say, if you take Pooja's recommendation that we have, stratified data and thinking about that, there's kind of a question of how are you going to look at that and measure that and sort of put that in there in a way that's easy to be done and something that could be universal. So I was actually asking.
Yes, well, we can do it. Micropolitan and non-core and adjacent, non-adjacent, I think is a good basic infrastructure that most data systems can handle and is pretty universally applied. There are still problems because some counties are tiny and some counties are huge. San Bernardino County, like there are definitely rural parts of it. And so we need to be aware of those limitations as well, but that's a good place to start.
Great, thank you. And why don't we come up front and then we'll go to the back again.
Allison Northrup with the Association of Maternal and Child Health Programs. An addition for indicators of success, we mentioned thinking about the continuum of care, and so increased attendance at the postpartum visit could be facilitated by Medicaid coverage for things like transportation.
Great, thank you.
I don't know exactly where this request goes, but I think we need a lot better information about what happens to women on Medicaid in terms of just data, understanding how they qualify, how long they stay on the program, how much it costs for them to be on the program, what types of services they're getting. I think that there's a lot we don't know about what's happening, and a lot of the data that we have is pretty dang old, and some of it's proprietary, and the managed care plans are holding on to it. So I just think that publicly making that data publicly available and available in a way that is time sensitive is really important to be able to respond in a meaningful way.
Yeah. Great. I think that probably could fit in the lever box. That's one of the resources that's needed. It could be in the facilitators. So we'll figure out where to put that. Yes.
I think one thing on indicators of success are, and Seema Verma mentioned it this morning, that when policy comes forward or legislation, she thinks about it from how is this going to affect the patients in the rural areas. And Dr. James's entire department thinks about that, and we heard that CDC has the same thing. I think a lot of times, whether it's a payment issue or whether it's a legislative issue or something like that, many times the answer comes from an academic, well-researched type of solution, but it doesn't have a rural lens on it. And I think encouraging national as well as state governments to kind of look at some of this from a rural lens standpoint. And I'll give you an example, and I'm going to start a firefight here, and I apologize. I'm not an obstetrician, and also I'm a dude, so this doesn't apply to me directly. But when you look at things like the 39-week induction rule, that makes a lot of sense for a lot of reasons, but the impact in a rural area is really different than the impact in an urban area. Whether it's right or not, and I'm not, it's another dude, and okay. but whether you can have, at 38 weeks and 4 days, an induced delivery because someone lives an hour away and their transportation's iffy, and your call team's not involved, I'm not saying whether we should change that philosophy or not, but it really needs to be looked at from a rural lens. And I think the more we can encourage people looking at payment or other pieces like that from a rural lens, at least we know it's been addressed.
Great, thank you.
And I will just add for everyone, and especially those who are participating virtually, for the administrator, one of the big priorities that she has is burden reduction. So if there are, payment rules and things that you really want us to take a look at, please let us know sort of in detail. The more detail we get, the more we can actually act on it. But I would just encourage you, if there are specifics like that one to take a look at, let us know those.
All right, thank you. I want to ask the impact and effort question for this one. So I'm going to ask folks, if we're talking about these changes and Medicaid reimbursement and expansion, et cetera, raise your hand if you think that some of these changes would have a high impact on care in rural communities. Okay. Raise your hand if you think this would require a lot of work, a lot of effort. That second one always gets more hands. Although
this one's easier than
this one, yeah, it is. It is. It is. And are there any next steps that folks want to we can pull out some of these nuggets that you've given us, but are there any kind of concrete next steps that you really think are important for us to consider moving forward? Oh, everyone's running at once. You win.
Okay. I think that in terms of payment to rural facilities for services, if we could find a payer-provider partnership that's been that's accrued a contract that's fair on both sides, and then begin to feature that as a model, because I think we don't really have the tools to understand what is fair, and if we can find some best practices that enunciate that, then I think that would be helpful.
Perfect. Thank you.
Sure. So I think that one of the things that is an important next step here is to conduct policy-relevant research, recognizing that state policymakers are one of our key stakeholder groups here, and that they control budgets. We need some understanding of the financial costs and the quality benefits and the impact on state budgets for experimenting with Medicaid reimbursement to include some of these features. That's something that we did with doula services and has been very helpful to state-level decision-making. Before that, there was a lot of great clinical evidence, and we have a lot of great clinical evidence about some of these things. But the fact is state policymakers need data on which to make decisions about their state budgets. And I don't know if that comes in the form of like a CMMI grant to rural communities to expand this, drawing on the data that we're going to get from the RMOMS program through HRSA. I think that increasing the evidence base to allow state policymakers to experiment in this way is going to be extremely important. Thank you.
Great. Thank you.
Tom, I think you have a research topic.
Hi, Sandy Lloyd from the Maternal and Child Health Bureau. I just wanted to do a point of clarification and a next step, because up above we were talking about no society for doulas, but, and correct me if I'm wrong, and I just looked it up because I've actually been familiar back a ways with them, but the Doulas of North America, DONA.org, is the association that has training and certification for doulas. So I think a next step could be to look closer at that and whether or not, like, what are the requirements as far as cost, and is this something that we could help them to ramp up and try to get more community, people within the communities, within the rural health communities, trained and certified, and again, follow up with whether or not their services could be reimbursable. But
Great.
DONA is what you want to look up.
Thank you.
You're welcome.
Appreciate that.
Just to speak to that, DONA is one of the largest certifying organization of doulas in the country, but it's not the only one. And so it's a great group to convene with. Also, and I think DONA would acknowledge this, it's a predominantly white led institution, and most of the doulas that it trains are white, and there are other more culturally based programs and training programs and certification programs. So it's not... it's a great leader and a good organization and worth engaging with, and it's also not the only voice. And so that's just something to note.
Yep.
Certainly.
Right. Great. Thank you. I think that's a great next step. All right. We're going to move on. And so, Sarah, I'm going to ask if we could go back to, or go to the workforce slides. And we had a part one and a part two. It's really hard to kind of tease these out. These things are all related. So I am going to just review the slides again and then ask people, I'm going to ask someone to get up and tell me what the priority is. We're just going to start there because there's a lot that's here. So, one was about encouraging and supporting all those different training opportunities that people have brought up many times. Another was about increasing the number of rural providers that have some competencies, again, related. And another was about looking at some of those other models like doulas, midwives, et cetera. Slide 2, if you go to the next one, please, Sarah. On increasing opportunities here, we talked about incentives and starting incentives earlier, looking at loan repayment as a really critical incentive and expanding that, but also thinking about other kinds of models that could help support it, possibly tied with loan repayment. And then collaboration. We've talked a little bit about some of that, but around team-based care and looking at family consultation. So there was a lot that was talked about in terms of kind of from the starting early, having good recruitment opportunities, providing different training opportunities, providing incentives, and increasing collaboration. But I want to throw it back to the group to see if there is a priority that you'd like to start with. I see you ready to jump up.
So, Jean Howe, Indian Health, just want to again talk about what it would mean for the workforce in the rural ERs that aren't ready to take care of women with pregnancy and postpartum complications. So, standardized training, reimbursement, a set of resources that helps those ERs be ready. What if there was some funding to actually make sure drills happened? And another piece of the workforce that we did not really talk about at all today is the transport network. We often can't get people out of our most rural facilities because the EMTs and paramedics and nurses that would take them may not have that skill set either. So we have a bigger workforce to talk about to get all the systems we need in rural America, but I'd like to make sure that we don't lose track of the ERs and the EMS system.
Comment in the back.
Well, actually, I was hoping to combine two.
I love it when people combine.
Yeah,
That's
which
good.
is the training opportunities and loan repayment. I do think that those are related to each other. And I'm not sure exactly what form those should be, but that's one of the biggest reasons why people don't go to rural communities is because of those loans. And again, we just really need to increase the number of training programs for rural communities in particular.
Great, thank you. In the front?
Sure, I actually wanted to combine the same two. So there you go.
Right.
So the loan repayment is so important, as we've all heard, and the Improving Access to Maternity Care Act was signed into law but hasn't been implemented yet, and that's just waiting there to be able to get OBGYNs who already are in the National Health Service program into maternity care areas of shortages, and so that would be really a twofer. It helps them pay off their loans, but it also helps ensure that they go to areas where their particular kinds of services are most needed. So I would highly recommend that. And then, as we heard from the University of Wisconsin, their fairly new program to have a rural residency for women's health care had 100 applications for one slot. So there's definitely interest among young people in going into those areas. And it was pointed out to me by one of our doctors who's here today that the rural residency program that HRSA talked about today is available for internists and family physicians and psychiatrists, but not for OBs. So I think that's an area we should really think about that and make sure that we are making these available to OBGYNs as well, if that's part of our mission of getting care out to women wherever they live.
Okay, thank you. Great, thank you.
Hi, it's me again.
Yes.
I have a policy suggestion that I want to link into the loan repayments and training combo that's been brought up.
Can I say, yep, Sarah, you got it.
Yep. There we go.
Thank you,
We're
Sarah.
getting there. We're all together here in
we're on
this
the same page.
conversation. It's great. Is the idea of low volume reimbursement adjustments, low birth volume reimbursement adjustments. And this addresses the barrier that was brought up earlier that there needs to be some liquid assets to bring on board those National Service Corps folks to hire them, even if their loans are getting repaid. There needs to be money to pay their salary and get them in the door. And so the low volume adjustments directly address the challenges that rural hospitals face and had the fixed costs of having being ready to handle a birth at any time of any day or night, combined with the variable cost of your revenue only comes with the pregnant people that walk through the door and is also affected by the payer that's attached to that pregnant person walking through the door. And so low volume, and I know that's something that several states have experimented with, but if there are ways to facilitate that, to provide guidance through CMS, to strengthen that, I think that not only addresses the financial viability question, but also just speaks directly to the workforce questions. I don't think that's the the only solution. I think it needs to be in concert with other things, because just paying more for a thing that's already not functioning very well won't necessarily. I mean, just staving off closure for an additional amount of time is not what we're trying to get at here. But I do think it could address workforce issues. Great. And the other policy suggestion that I have here is probably under relevant stakeholders. And I think it is important for the workforce issues. And I also would like to offer it as a policy suggestion for the other spaces as well, which is the role of rural representation. Having a rural provider, a rural patient, a rural community member, a rural person in the room when decisions are made about these quality indicators and what they should be, having someone who practices in a rural setting be like, that makes absolutely no sense in our setting and here's why, whether it's the early elective delivery rule or other types of rules, but having a rural person there. Also having rural representation when funding decisions are made. Rural places have fewer people, and if there's a bang for your buck mentality around funding decisions, whether that's CMMI grants or other types of grants that come out, unless they are specifically designated for rural areas, rural places are disadvantaged in that. So I think, and I would also argue for maternal mortality review committees. We do not have a requirement of rural representation in these committees, but having a rural voice present in all of the maternity care work that we do. Altogether, too frequently when I'm at national meetings around maternity care, I'm the only rural voice or one of few rural voices, and I live in the Twin Cities. And that's not rural. I'm from rural places. I know there. I got cousins there, but that's not like, we need people that live and breathe rural life, offering their perspectives in all of these workforce discussions. So I think that that's something that, as much as we can weave it into policy suggestions or requirements, it's a really helpful change. It will really shift the dialogue that we're having.
Great, thank you. Let's go to the back again, and then we'll come back up to the front.
Hi, I'm Teresa Baker. I'm with the American Academy of Family Physicians. And AFP is actually working with Congress, developed a number of bipartisan bills that I hope you'll find interesting and helpful. The first is advancing medical resident training in rural hospitals, community hospitals, HR 1358. It's a bipartisan bill that would allow for hospitals that have had rural rotators come through and are not eligible for to establish residency programs. This basically inoculates them and sets a payment for them. The Rural Physician Workforce Protection Act, again, a bipartisan bill. This is in the Senate, S 289, that would establish and fund rural training tracks, and also allow for payment for IME and DME for residency programs in rural areas. And it bears saying, and people have mentioned it, but the Teaching Health Center Graduate Medical Education Program and the National Health Service Corps and Community Health Center programs all expire on September 30th. We're hopeful that we won't fall off that primary care cliff, but it's happened before, and so that's coming very soon, and I'm perpetually nervous about that sort of thing. And one of the other issues that bears on workforce is the primary care training grants under Title VII. Because the AFP is also very engaged on that, as I know National Rural Health Association is, and just like to raise that as another workforce component. Thank you.
Thank you.
I just wanted to add support for interprofessional education. Also, I wanted to pose the idea of rural research, because when we're talking about National Health Corps and my experiences with nurse midwives and nurse practitioners coming to a rural area, being very shell-shocked over the whole situation and not being happy there, and going home every weekend, or going home every time they could, and leaving as soon as they possibly could. So the idea of a rural residency sounds very attractive to me. So before we put a lot of money into one or the other, or what is the data showing on how long those types of residency stay in a rural area?
Great, thank you. Yes.
So the next item, and it's kind of related within this grouping, so forgive me if it's not. One is credentialing and performance competency assessments, and how do we do low volume credentialing and recredentialing when we don't have case loads that give you the numbers that you necessarily need in that context. And I think that we need assistance in rural hospitals to do that. I know there's been some best practices around that in some locations. The other thing is, shifting to another topic in rural hospitals, is the cross-training of workforce. And we talked about nurses who are pivotal to the delivery programs in rural hospitals, and how they often are not dedicated to obstetrical delivery. They work the emergency room, they're on the floor, working in the med-surg, maybe even going into surgery at times. So these are the realities, and I think that some kind of help in terms of recertification for things like NALS and PALS, I mean, all of the various details that go into keeping a really robust program within a rural hospital active and vital.
Great, thank you.
And I didn't pay him to just segue into what I wanted to say. But just really quick, we were talking earlier about drills, which are so critical, but also we were talking about the levels of care. And continuing education is so vital, especially in our rural hospitals and our rural workforce. So I'm thinking that, again, if we can use those higher level hospital centers that are potentially supporting the level ones and the level zeros, as we talked about, that any continuing education that they're offering gets also offered to the rural workforce, either virtually or whatever, so they're never forgotten. I mean, they're basically pulled up and involved in any kind of continuing education that's being offered at the larger facility.
Great, thank you.
Hi, it's Jean again. For rural facilities, for low volume birth attendants and nurses working in low volume settings, it's great to have folks come out. It's great to have CME offered virtually, keep up the training, but sometimes we rural folks need to go in. And there's a great model in Alaska where these very small birth centers around the periphery of Alaska send their family physicians and L&D nurses into Anchorage to ANMC to spend a week or two on labor and delivery there and experience higher volumes and see higher risk patients through the birth process. There are barriers to doing that with credentialing and coverage, but for our system that has worked well, and it's keeping. I heard some comments about regionalization earlier that made me think some of you don't like that word. We want to be part of a big regional network that supports us well, and that doesn't just mean you come out and tell us what we should do better, but that we go back and forth.
Thank you.
So this is actually the first year that people could get public service loan forgiveness if they've spent 10 years at a nonprofit facility. So when you're talking about loan forgiveness expanding and all of that, do we know if this program is helping rural facilities? And are these rural facilities nonprofits so these people are eligible in the first place? So I just kind of feel like you should keep in mind the fact that there's this huge program that maybe people could take advantage of before starting another program or expanding an existing program.
Right. That's a great point. I think a couple of people have kind of mentioned making sure that the programs that we have do work and figuring out what makes sense. And so one of the next steps might be some kind of look across the different programs that are out there to look at some of the evaluation data that's there. And if there isn't any, figuring out how to figure out what really works. Katie.
Shift our gears a little bit, and I'm not sure exactly how to connect this directly with the topic, but it occurs to me in this context, and I think it's something that I haven't heard spoken of much in our discussion of solutions, and that is access to family planning services and addressing the health of folks prior to pregnancy. I think in rural communities, we've seen, so speaking of things that work, we've seen a major reduction in teen pregnancy rates in the United States. I want to point out that that is not seen in rural communities, but we don't divide our data rural urban, so we don't see that. But rural teen births are not declining. And it's really important that when we're thinking about the workforce that we have, that we're not just thinking about folks that can catch babies, but also access to services to prevent pregnancy for folks that want to prevent pregnancy and be able to space their births appropriately. If we want to be, using high value investment of our scarce resources in Medicaid and in other programs, investing in pregnancy prevention and contraceptive services for those that want to, and ensuring access to those services is vitally important.
I'm going to clap for that one. Thank you. Yes.
Kathy Hull. I'm from West River Health Services in very rural southwest North Dakota. I think just to address stakeholders, medical schools, medical school admissions committees, nursing schools, nurse practitioner training, physician assistant training. I'm in a critical access hospital, 25 beds. We have a rural training track for family medicine. We train PA students, medical students, nurse practitioners, nurses, pharmacists. We have 8 physicians on our medical staff, and we take care of 20,000 patients in 20,000 square miles. And our physicians can't get loan repayment because our county has 8 physicians, but the 12 counties around us have 0. Unfortunately, because of our county location, we can't get loan repayment for almost any of those people when they try to come out to live with us. So it's a barrier, but also those are some of the stakeholders that have to come to the table and say, yeah, you're going to come to our nursing school and we want you to go out and see what it's like to be a nurse in a rural hospital. Yeah, you want to come to our PA program, you have to go out and see what a PA does in a rural hospital and a rural clinic network.
Great, thank you.
Skip Johnstone, North Carolina. I'm faculty. Where am I looking? One next step, is that at the bottom?
Yeah, let's do next step.
Yeah.
Yeah.
Get graduate medical education folks involved across the board, not just in obstetrics and family medicine, because this may be a new theme that needs to be run in all education residency programs.
Great. And that's a good segue because we're bringing this one to a close, but are there other thoughts on next steps? Things that should happen. One was kind of looking at some of the data that we have around existing programs around repayment and training opportunities. The idea about involving folks from across the spectrum, including GME folks. Other thoughts on next steps? It's the 417 slump, right? Almost there. Somebody give me one next step. Here we go.
I'm not even sure if it's the next step, but
it's okay. I'm going to put it in that box.
All right,
regardless.
very good. All right, so most loan repayment programs are for 3 years, and that's a problem because it actually takes about 5 years before you start feeling like you're a part of the community. And so loan repayment programs actually need to be for a lot longer. First year, you can't do anything wrong. It's like this honeymoon period, and everybody just thinks you're fantastic. The second year, you can't do anything right. It's like you're a parent of a teenager, and they turn 13 and you wake up and you're stupid. That goes on for 2 more years. And then the 4th year, then all of a sudden people start to think that you're doing okay. And by the 5th year, then that's when then there's confidence in the community. And some states it's worse, it's 7 years. But 5 years is something that at least would capture. That's what I've seen is that one of the reasons why loan repayment programs don't work as well is they're there for 3 years. And at the end of 3 years, they're at their lowest ebb when they just feel like they aren't doing anything that is worthwhile. And that's when they leave.
Yeah, that's a great point. Thank you. So I'm going to ask for a last show of hands. So we've talked about a number of different kind of strategies around workforce, but really this idea of increasing training opportunities. And I love the fact that people talked about training opportunities as folks are coming into their careers, but also continuing that kind of education and the idea of cross-training folks within systems. So there's a lot that's there. But so thinking about, those training opportunities and really kind of expanding the way we're thinking about loan repayment, I think is important. Continuing to enhance the program that we have, but also thinking about other kinds of incentives. So, keeping that kind of those big ideas in mind, show me if you think that these kinds of opportunities would have a high impact on the workforce in rural areas. Okay. Show me your hand if you think this would require a lot of work, a lot of effort. Okay. It's about half and half.
Yeah, I'm a little surprised.
I am too. All right.
So I have to say I'm a little surprised because in looking at the hands that went up for high impact, I might have expected a few more, which kind of begs the question, if this isn't the sort of big thing that we need to be doing, what is it? And again, can kind of let us know. But I was a little surprised. I would have thought we would have had more hands go up, and that says that we need to think a little bit more about this. But
yeah. Great. All right. Well, I want to thank folks so much before I turn it back over to Kara for your willingness to participate in a large group discussion around priorities. And this was really helpful in giving us some ideas. And again, we're going to take back all of this information from the conversation, from the stickies, from the online participation, and really get some, I think this is a really good start to some ideas about what some critical next steps would be. So Kara.